Okay, so we're going to try and stick to kind of the basics of both tumor immunology and then the small molecule inhibitors that we are using more and more commonly and we're finding more and more indications for. I was just saying before I pushed record that I didn't meet my expectations of pre-reading here just because I kept going down rabbit warrens because this is such an interesting and emerging field, but a lot of the information out there is just not relevant to veterinary medicine at the moment and or particularly not relevant to, it's not examinable at this point. I'm sorry if everyone can hear the background noise in my house. Is it all right? Okay. Everyone's like, there's something roaring downstairs. I'm not sure what it is.
I can't hear anything.
Yeah, I can't hear anything actually.
Okay, super. Okay, so the topics today are tumor immunology, which includes what makes a tumor recognizable to the body and what the body can do about a tumor in health or a cell with a mutation in health to stop it from becoming neoplastic. And then second topic is going to be small molecule inhibitors or tyrosine kinase inhibitors. And we'll talk a little bit about the kind of applications and what we know about them at this point, what we're using them for. But as I said, very rapidly emerging field. So what mechanisms does the immune system have of recognizing that a cell isn't right if there's been a mutation?
It's got its different checks during growth phases.
Yeah.
So you can tell if DNA didn't replicate properly or organelles are not functional. They can stimulate apoptosis.
Excellent. Good. And what about once you've got a mutation and it got through those checks and that cell's kind of started to replicate itself?
Then you've got your tumor suppressor genes that kind of kick in, I think, and try and suppress that.
So that's why it's sort of one of the cell cycle checkpoints, the tumor suppressor genes. So it's completely correct, but it's probably doubling up. Like if I was a marker, I'd still only give you 1 mark for that. And it's probably a sign that I've asked the question poorly. What are the immune system's ways of getting rid of bacteria or viruses or intracellular organisms? Like, how does the immune system kill stuff that shouldn't be there?
Like
and in this, sorry, go ahead.
To the macrophages through MHC and then toll receptors.
Good. Yes, exactly. So MHC molecules present antigens on the surface of the cells, don't they? And that then allows parts of the immune system to recognize those cells as either abnormal or normal. Are tumor cells going to be presenting normal antigen or abnormal antigen?
Abnormal.
Well, they're kind of, it's interesting because they're made up of self. Like, how does the body recognize that they're different?
Maybe the body doesn't. That's why we keep replicating.
Yeah, well, but there are a lot of examples of the immune system being able to clear cancers. Like there's spontaneous resolution of tumors which haven't undergone any treatment, and the immune system's cleared them. We know that osteosarcoma surgical biopsy sites that get infected have a better prognosis than those that don't get infected. How cool is that?
I didn't know that. Oh,
yeah.
So maybe we should infect them.
Well, it's part of one of the kind of concepts, the theories of how do we stimulate the immune system to try and target tumor cells. So there's lots of sort of examples that the immune system, if they can recognize that that tumor cell is abnormal, it's a really nice mechanism for potentially very targeted anti-cancer therapy, as opposed to chemo, which has more widespread effects, radiation, which will affect healthy cells as well. So because the tumors are kind of made up of self DNA and stuff like that, really the only difference is the amount of stuff in them, which is abnormal. So we're going to have less tumor suppressor genes that Josh said, but we'll have more oncogenes, won't we? So things like P53 and things like that. So the list that I've got of things that will be potentially overrepresented on the surface of these cells. So MHC will just keep putting up the same thing over and over again, and the body will start to go, no, there's too much of that in there. A P53, which is one of those oncogenes, RAS, R-A-S, and P21, which are just things that are kind of overrepresented. Now, the reason that I mention these molecule names is because they're going to pop up in the discussion on intracellular signaling. These molecules often make up part of the intracellular signaling that we're blocking with the tyrosine kinase inhibitors. Have I blown everyone's mind already? Too soon? Yeah. So particularly the RAS one is one of the main ways that tyrosine kinase inhibitors, let's get to that later. Sorry. Too deep. Okay, so going back to basic sort of immunology, the immune system has a few different mechanisms for getting rid of something in the body that it doesn't want there. So I'm going to break it down into innate and adaptive immunity. And now I want you guys to tell me within those what mechanisms there are. So Pooja mentioned the macrophages, which is one of the mechanisms. So MHC says there's something abnormal in the cell, and then we activate macrophages against that abnormal something. So that's one of them. Give me some more.
You have cytotoxic T cells, so CD4.
Excellent. Good. Anything else?
Off the back of that last one, natural killer cells.
Excellent. Good. Adaptive or innate?
Innate.
It's kind of in the middle.
Middle, yeah.
It's interesting.
Depends what the Tregs effector cells do.
Yeah. Exactly right. So our kind of really simplistic knowledge of like innate versus adaptive is now getting a little bit more complicated now that we know the cytokine interactions between both of those. So cytotoxic T cells we've done. We've got macrophages, natural killer cells. What? Tell me about the adaptive immune response.
Is that the antibody, the plasma cells making the antibodies?
Exactly. Yeah. So you might make antibodies against tumor cells. That'd be handy.
Mm-hmm.
How do antibodies work?
I don't know if we do though.
Yeah, you can. Yeah, absolutely. That's one of the responses. Once a cell is marked with antibody, what happens to it?
Antigen antibody immune complexes form, and then they're deposited, and then that's another story.
No, I mean, how does the cell die? Because the cell is the antigen, and the antibody. So once they're bound, and that cell presumably isn't going to get lodged anywhere. Hopefully, it's stuck in a tumor and not spreading around in the kidneys.
Phagocytosis.
Beg your pardon?
Phagocytosis.
Good. Yeah, exactly. So it will activate macrophages potentially. It will potentially activate the natural killer cells, depending on the interactions what the FC receptor looks like. What about, there's another like just weird part of the immune system that doesn't really fit into either innate or adaptive, and it's really good at killing cells.
Is it
it's not a cell.
Is that chemokines?
Oh, yeah, I love that, but that's deeper than I'm looking. So we've got like phagocytosis, we've got cytotoxic T cells, natural killer cells, and then little proteins that nobody really knows what they do, but we actually do know what they do.
Do about like opsonizing cells, like
oh. So this whole kind of pathway cascade, some of the proteins opsonize, and some of them can combine forces and make a complex which punches holes in cells.
Immunoglobulins? Oh, no.
Starts with a C-O-M.
Complement system.
Yes.
Oh, yes.
Excellent. Good. So the complement system forms the MAC attack complex, the membrane attack complex, which punches holes in cells once they're marked for destruction. We got there in the end. So we've sort of established that there's difficulties in tumor cells being recognized as non-self because they are kind of self. But once the immune system recognizes them, that the immune system is going to improve outcomes by very targeted killing of those cells.
And is that the concept of cellular differentiation?
Ooh.
The like kind of invisibility cloak, uncloaking of cancer cells?
Oh, do you know what? I think cellular differentiation is used in multiple different areas, and I'm not sure what the definition would be in this, because we talk about sort of cells being differentiated as far as how close to stem cells they are versus how close to well-differentiated cells. So like, I'm not sure where that would sit.
Yeah, I think it's more like immune system surveillance, making immune recognition of tumor cells. In that, I thought that was the context that I'd heard cell differentiation different from kind of stem cell transition.
Yeah. I'm not sure. I was actually reading about this and I was like, God, I wish I'd tapped in an oncologist to be. That would have been really helpful. So when we're talking about immunosurveillance, and I want to just put this into kind of my like order and ways of kind of thinking about things. The way a tumor kind of escapes from the immune system, or the way the immune system interacts with a tumor, is called immunoediting. And there's sort of 3 phases of that. The first phase is immune surveillance. So where the immune system recognizes that that tumor is not self and destroys the cells. The next phase is called equilibrium, where because of genetic adaptability, like cancer cells are really good at changing their genes, or factors like creating its own inflammation and kind of confusing the immune system almost, we start to get cells surviving the mechanisms the immune system has. And that's where the kind of equilibrium is, where the cell death is kind of equal to the cell survival, and we're not growing at that phase. And then we get an escape phase where the immune system is not keeping up with cell growth, and the mechanisms the cells put in place, either because they're poorly immunogenic or they actually suppress the immune system, will mean that the tumor can grow. And the reason why, I guess that's a nice way to think of it, is when we're treating tumors, we are either aiming for cytostasis, we're aiming to get back to that equilibrium phase, or we're aiming to make the immune system drop the cells down, drop the cell numbers down, so actually shrinking the tumor size. What ways would a tumor have of suppressing that immune response?
Well, putting out suppressor genes, immune suppressor genes.
Which is
turning off
cytokines.
Turning off P53 suppressor genes.
Yeah,
that's kind of not really about immune. That's more about, I think, just growth in general.
Cell growth. So that's going to be pro-growth.
Yeah.
But what they often do is actually produce cytokines, which create an environment that favors the T regulatory cell production. What do Tregs do?
Downregulate the Th1.
Exactly. So they upregulate Tregs, which then produce cytokines locally in that area and systemically, depending on the cancer, which decrease the activity of the other pro-inflammatory or pro-immune T cells.
Do they also, within the tumor microenvironment, with respect to like COX-2 or like they want pro-inflammatory for cancer progression too, don't they? Or,
to a certain extent. So pro-inflammatory brings immune cells as well. So it depends on the cancer's ability to evade the immune system. They want angiogenesis for sure. They want stromal cell, like they want structure to try, because a tumor that isn't held together is not a very good tumor if it's just kind of falling apart.
Because that the epithelial to mesenchymal transition?
Oh God, I don't know. I can't even remember what mesenchymal means.
That's okay. So I think more matrix, like more matrix building.
Yeah. What sort of tumors have you heard? What context have you heard that in?
Oh, all of them.
All of them. Yeah.
Yeah.
Okay.
Part of the part of the metastatic process.
Yeah.
Sorry, I had to jump on this call because I saw immunotherapy, and even though I've been on parental leave, I was like, "This is I'm super interested in this."
You're gonna challenge me, and I may start deferring to you to answer questions.
So don't do that.
I
know the words. I don't know what they really mean. That's what I'm trying to use there. So don't worry.
I think if you think about how a tumor develops, we've got one cell that's going to mutate, and that doesn't make a tumor, and then you might end up with 4 cells. But if they then just fall apart and end up just getting like filtered out by macrophages and normal kind of innate immune system, because it doesn't have any of those local immunoprotective effects or any kind of stromal tissue to hold it together, it's not going to go very far. So that's one of the things that tumors do to survive, is produce factors which will encourage angiogenesis, and that might be inflammation. But what was that chemical that we talked about last week? Josh gave me the answer last week. That stimulates angiogenesis.
Stat 33.
No, it's a
VEGF.
Yes, good. Yeah.
Yeah.
And what stimulates stromal cell growth? Do you know?
Insulin growth factor.
Insulin growth factor? I don't know if that's specifically for stromal cell. It's definitely growth. Like it will stimulate tumor growth.
Would it be things like KIT? Or is that more angio as well?
Yes, KIT. Yeah, absolutely. Yeah. That's one of them. And there's a fibroblast. Oh, sorry, go ahead.
I was thinking agnors as well, kind of in that ballpark.
Oh God, I don't know. Maybe. There's fibroblast growth.
I'm just firing off markers now. I don't know which ones they mark though. I can't remember. Yeah.
I think that there's, now that this is one of the areas where I kind of rabbit warrened a bit, and I was like, oh no, there's so many like little acronyms that I used to know what they meant, and now there's more, and I can't remember anymore.
PPAR's probably there.
It's not on my list, but my list is now 8 years old.
Did you say fiber as in like FGF23, like the kidney?
Oh, not in the not specific for the kidney, but fibroblast growth factor.
Yeah.
Which is just in stromal tissue. And
this
then
sort of stuff is like, because your question was more about how does it evade the immune system, so it's more the disguise type stuff rather than the it's like, I'm sure there's a lot of crossover, but it's not just like their tumor progression, but actually what are the immune mechanisms, right?
Yeah, so we started with what the immune mechanisms were, but then my subsequent sub question A was, how does a tumor make itself from a cancerous cell into a tumor? And it's through the development of blood supply and stromal tissue, which is going to allow it to kind of create a structure. And those two things, and the kind of the perpetuation of those two things, are essential parts of, like, whatever mutation has happened in those cells, it has to perpetuate those things, otherwise it's not going to be a very effective tumor. Okay, what else do we want to cover here? So as far as how we are now using the immune system to target cancers, can anyone raise any examples of how we're doing that actually clinically at the moment?
The only two that I know of, one is the melanoma vaccine, so the onset, which I've seen used. And the other one is, I remember there was some research coming out of Sydney Uni where they were trying to, like, I think, blend up an antigen in a way, being the tumor, and then how does it, well, I don't really know how that works though, but they're the only two examples I can think of clinically.
Yeah. Let's talk about the melanoma vaccine. What's that?
I think it's it's essentially a vaccine to try and spark the immune system to target and mop up cells, a bit like the way we would use chemo, I guess, but use our own immune system. It's used as like an adjunct anti-cancer treatment, I think.
Yeah.
After radiation, surgery, those kind of things.
Yeah, so it's definitely not a replacement, and there's variable responses in the literature. There's a paper that sort of showed it was wildly effective, and then another paper that showed it wasn't effective at all, which is concerning for veterinary literature, but that's kind of what we've come to expect.
I think they need to stratify the two groups based on the tumor, the situation to know which ones that they're effective in. I think that's a problem with Oncept, is that it is wildly successful, but it's unpredictable to know which patients are going to have the wild success. So it's probably like c-Kit positive status for a tocoranib in a mast cell situation, that they just haven't kind of worked out yet which ones to use it in from a pharmacogenomics perspective.
I think that's actually a really interesting point that my rabbit warren led me down. In humans, there's been so much work on the molecular components of neoplasia in humans. We don't know that we can extrapolate from that for dogs. And a lot of this sort of translational oncologic research is applying theories that are from human research without the background. Do dogs have this same molecular way of, I mean, we can sort of say, B-cell lymphoma is similar in dogs and humans. Let's use dogs as a model for human disease, but we don't actually know that all of the intracellular signaling is identical, because that work hasn't been done in dogs. So there are big holes in then applying molecular therapies to dogs when they've got potential promise in humans.
The melanoma one, the Oncept, like that one is like it's human melanocyte targeting, and it just has cross reactivity with dogs. So potentially there's a bunch of dogs, it might be based on what blood type the dog is as to what whether you get the antigenic stimulation from the human vaccine or not. I guess we just don't know, but I believe that the human melanoma and canine melanoma are not the same molecular pathways.
Oh, right, okay. So the melanoma vaccine is a DNA vaccine. Do you know what that means?
That it have inactivated tumor DNA within it, or particular markers, antigenic.
Good. Yeah. And in the melanoma case, they're directed towards the tyrosinases, which is a pathway that is, like Matt said, exclusive for melanoma cells, but not all melanoma cells. But we don't have the tests developed in dogs to know which dogs are going to respond and which ones don't. So it's just trying and erroring, basically.
And I think it also targets healthy cells because they can go grey from it.
Right. And because they've got fur, not hair. That's cool.
And interesting, black dogs need 30% more tyrosine in their diets to keep a black coat.
Really? That's cool. What happens if they don't get it?
They get a dull coat.
Oh, where do you get tyrosine from nutritionally?
Protein, animal protein.
Animal protein, is it?
Yeah.
Oh, cool.
Yeah, I think that's the melanoma onset has that side effect that it can cause graying in dogs, which is probably a good thing because it means that it's probably also targeted the melanoma. As well.
Good sign. Yeah. So DNA vaccines are one of the mechanisms that we can stimulate the immune system to target a cancer cell. Oncept is a really good example of that, how we're actually using that clinically. And it's essentially injecting DNA in to then be translated and transcripted by the host cells and produce antibodies against, or cytokines to stimulate T cell activity against those cancer cells. So it just upregulates the cytokine production, essentially. So DNA vaccines are a really promising field that there's heaps of research going into at the moment, but there's nothing else clinically that's particularly relevant. So I don't want to go too deep in there. So we can inject DNA, or we can inject tissue, which Josh referred to stimulate an antibody response, so produce antibodies against tumors. And there's been a group in Sydney that have been working on this for years now, like 15 years or something. And they're literally, there's much more complex than this, but they're blending tumors and injecting them into the dogs again.
I can jump in there if you want a bit more color to that, because I've been doing a lot of that with Dr. Chris Weir from Royal North Shore, who's one of the clinical leads on the Sydney Uni lymphoma trial, and was also behind the KVAX failed trial at SASH, I believe failed or discontinued. But what that is, it's similar to the Oncept one in that it's it smashes up, inactivates, and produces DNA specific to the dog. So it kind of, and I have no conflict of interest in saying this, I'm not able to hear as a spokesperson for it, but it's similar to Oncept, but it actually finds the proteins that are relevant to that dog's tumor. And it's mostly through T cell mediated destruction. But then what they do now is they add like a calcium nanoparticle to it. And then it works even better if you have some DNA destroying chemo adjunctively, so that it smashes up the tumor, lyses some DNA, so there's a better chance. So something like vincristine, and then not using it. It's now sort of starting to emerge through the signals from the from the research that it doesn't work if they're on pred, and not so it doesn't work so well if they're on Palladia. So it's showing most promise in MCTs and osteosarcoma. Which is interesting because it goes back to the osteosarcoma insights around infection, like ramping up the immune system with a native infection, and then better outcomes in that kind of more immuno-naive tumor perhaps. And then don't know yet couldn't comment on the lymphoma outcomes from the trial. But yeah, they're the kind of mast cell and osteosarc are the ones that seem to have been starting to show some positive signals, early positive signals.
Yeah.
Yeah, I think it's an interesting one. And Cornell are also doing a universal vaccine for cancers, which they're trying to develop to actually prevent lymphoma, hemangiosarc, MCT.
Wow.
So that's happening at Cornell. So it's happening in parallel elsewhere. But yeah, the autologous immunotherapy is the one that's been going on in Sydney for a long time. But the good news is that even though it's been happening for 15 years and it's not really got momentum, the nanoparticles, the calcium nanoparticles and the adjuvant technology seems to be improving more to the point where it might have commercial viability.
It's a really interesting field, and particularly because it's available for us locally. Anyone that's in Sydney, if you're taking out a tumour.
Oh yeah, we've done one together. I forgot about that.
Yeah, we have. Yeah, exactly. You know, I've done a few, and more. I mean, often it's sort of a liver tumour or something like that where we've excised it, so we can't measure response, and we sort of say, "Oh, it hasn't recurred. Is that because we're doing immunotherapy or because we got it all out?" And we don't really know. And it's one of the things that's sort of hard to measure. But the nice thing is it's an incredibly well-tolerated treatment option. And for those clients, it's actually quite affordable because it's funded by research funding. For those clients that decline chemo, particularly with things like mast cells and osteosarcoma, it is a nice option to be able to offer them. The main thing is that the tumours can't be formalinized. So you need to send part of it off for histopathology, but you also need to freeze part of it if you want the option of going down that road. And they pretty much will do it with any tumour, to my knowledge. If you can take it out, they'll generate a vaccine for you. Is that where they're up to still, Matt?
Pretty much. If it's lymphoma, they should, and they've got more than one month survival prognosis, then they can't get it outside of the trial. But everything else you can get through the Colling Institute, through Dr. Chris Weir, who you can contact through Sydney Uni.
Okay, so we've talked about DNA vaccines as far as a way of targeting the immune system. In DNA vaccines, we're targeting the adaptive immune system, and it's quite a specific targeted stimulation. Whereas, in fact, let's stay with a specific, like we're trying to generate a response that's very specific for that tumour. There's not going to be any collateral damage. It's not like we're just ramping up the immune system non-specifically. Is there anything else that's kind of emerging, to your knowledge, in that kind of targeting the tumour sort of space? There's a recent arthritis drug, a recent pruritus drug.
Monoclonal antibodies.
Yes, good, exactly. Yeah. What do monoclonal antibodies do? What does monoclonal mean? Clone of one?
One type.
Yeah.
One type.
Exactly. And we know what antibodies do, right? So if we're looking at the potential for monoclonal antibodies to be used in a tumour, how would they work, do you think?
Could be trying to activate or target cells or tumour cells with the immune system. So the only one I can think of is like R-CHOP. Have you, like the one where is it rituximab or whatever it is?
Yes.
It's like not really been proven to be very useful so far, but it's like bigger in humans. Part of your lymphoma protocol.
Yeah. I can't remember what rituximab is, but I think it might be CD20 monoclonal antibody, because that's really the only one that's being used commercially in veterinary medicine. So when you've got a suspicion of lymphoma, dog with a big lymph nodes, you've done your aspirates, you've sent it off, cytology is large cell, and you want to differentiate T or B cell. And the way that you differentiate T or B cell is by the markers on the cell surface. And one of those markers is CD20, and that's specific for B cell lymphoma. So they've developed this antibody against CD20. Oh my gosh, I love babies. Sorry. Hi. So they developed an antibody against CD20, so it binds to the B cells And then what happens once a cell is marked with an antibody? We've talked about it. Who can think of it?
Phagocytosis.
Yes, good. Yeah, usually macrophages, but sometimes complement can help when there's bound antibody as well. Good. So that's it.
Sorry, this is a bit of a rabbit, Warren, rabbit hole.
Yes, that's where I've ended up this morning.
The M1 to M2 macrophage, like activating factors and that sort of system. Have you ever deep dived into that? Like, there's a treatment in Japan called GC-MAF, and it plugs in with vitamin D, somewhere in the D3 pathways, but it's part of this there's like macrophage M1, M2 phase with the kind of molecular oncology, and that if you kind of manipulate that, you can get the macrophages to work better, maybe beyond the scope of today, but definitely throwing that in the ring is another area of the immune system that I believe is getting some attention with the researchers. Yeah, it's in my list of innate response types to tumors, and it can be M1 helps activate the T cell mediated anti-tumor responses, and M2 produces immunosuppressive cytokines. So actually facilitates tumor evasion. Right. So you want to go from M2 back to M1. M1, exactly. Yeah. I think that's too deep. Membership candidates, forget immediately. Sorry. Okay, so what I want to do, I want to kind of try and make sure you guys have got a bit of an ordered way of thinking about this. So when we're stimulating the immune system to target tumors, we're either going to be specific, and we're going to do that with either monoclonal antibodies, whole tumor vaccines, or DNA vaccines. And then if we're being a little bit less specific and not necessarily telling the immune system to target exactly those tumor cells, but maybe just stimulating the immune system a little bit. Can anyone think of any examples of that? Immunonutrition.
Ooh. Yes. So essentially any stimulation of the immune system. So has anyone heard of the bacillus? BCG of Calmette and Guerin? Yeah. So it's essentially like it's a mycobacterial component from Mycobacterium bovis that's inactivated and injected just to stimulate the immune system, essentially. So it's a non-specific immune stimulation.
It's a TB vaccine.
It's a TB vaccine.
Yeah.
Really?
Yeah. And it's used in elsewhere in the world, wherever TB is in the world, and actually found that it protects babies from COVID.
Oh, that's amazing.
Gives you a wicked scar, and if you grew up in a third world country.
Yeah. Or England. Don't English people have TBs? No? Maybe not.
Yeah, I think they did, but they might have weaned it out by now.
Yeah.
I think it depends on what time frame it was, the stage of economic development and the time frame of who has the scar.
Which generation? My generation have TB scars. Yes, so there's the BCG, and then there's another one that's not real, like it's not used commercially at the moment, but there's research that shows that it's been quite effective. Is like a liposomal kind of encapsulated immune stimulator, which binds and works specifically with macrophages and monocytes to upregulate their activity. I can't even pronounce it, so it's probably not something you need to write about. And then there's I can't even read that writing. There's a cream that we use on cats with Bowen-like carcinoma, squamous cell carcinoma. Bowen-like is a superficial form of squamous cell carcinoma, which hasn't penetrated the subepithelial layers.
That 5 fluorouracil or Ifedex or something?
That one's actually chemo, but there's actually another one called imiquimod.
Oh, yeah.
Have you heard of that one?
Yeah.
Yeah.
Is that a retinoid?
No. Well, I don't know.
One for SCC.
It's one that it stimulates TLR7.
Uh-huh.
Where have we heard about TLRs?
IBD.
Yeah, exactly. What are TLRs?
Toll-like receptors.
Yep. What do they do?
They sample the surroundings and give an immune system, like a complex to the immune system elsewhere.
Yeah, pretty much. So toll-like receptors are pattern recognition receptors, and the different numbers correlate with what pattern they recognize. So I can't remember what TLR7 is, but it essentially, if they recognize that antigen, they stimulate with all the intracellular signaling an immune response in response to that antigen. So if you've got a TLR7 agonist, which this cream is, you are constantly triggering a very specific immune response. So this cream is very effective against squamous cell carcinomas, is just triggering the immune system to work locally. And because it's used topically and superficially, it doesn't need to be very specific, because you can be quite specific about where you're applying it. Make sense?
Awesome.
And then the other point I'd like to make with non-specific is that the chemotherapy we use, particularly metronomic and the small molecule inhibitors, actually inhibit Treg cells. And if we know that tumours increase Treg cells to protect themselves, and metronomic chemotherapy and toceranib in particular decrease Treg cells, then that then kind of releases the immune system to do its job on the tumour. So it just removes part of that tumour suppression of immune activity.
Does that get classified as a checkpoint inhibitor?
I don't think so. Because it's cytokine mediated.
And what was the last drug you said, sorry?
Toceranib.
Oh, okay.
And metronomics, that was the other one. Chemo. So let's move on to our small molecule inhibitors. So the objective of small molecule inhibitors aren't really to shrink tumours. They're to limit growth or minimize growth. And having just talked about what tumours need to keep growing, what sort of effects might we want a drug like that to have?
To stop angiogenesis.
Good. Anti-angiogenic. Good.
Anti-stromal. Like,
good.
Oh, that's true.
Perfect. So they're the main two things. And there's a few different, like we talked about, a few different proteins that will stimulate stromal cell growth, but there's not that many that stimulate vascular growth. So when we look at how effective these drugs are, what we're actually measuring is VEGF within a tumour, or like epithelial growth factor within a tumour, to see whether it's working or not. What is a tyrosine kinase?
An enzyme.
Yeah. Do you know why I'm asking that question? Because I've been calling them small molecule inhibitors.
The TKIs.
Yeah. So tyrosine kinase inhibitors is the other name. Yeah. Everybody? So they are molecules, enzymes, which phosphorylate other molecules, basically. So where their role is in the context that we're talking about them in is they've got, I might have to do arts and crafts if my hands aren't working for everybody. So say the edge of my couch there is the cell wall, and you've got like essentially a receptor that bridges from the extracellular space up here to the intracellular space down here. Yeah? Is that all right for everybody? Okay, good. So these particular receptors are for growth factors. So a growth factor is one of the things that's produced in response to the oncogenes, increased growth factors. So all of a sudden we've got more growth factors and they bind at the extracellular spot. And then that makes these guys kiss each other in the intracellular side. And that interaction of the two sides of the receptor activates this phosphorylation process, which then I'm going to share my screen. Can everybody see that? So we've got, see, this was a much better way of explaining it than my hands on the couch. So we've got this receptor that traverses from the extracellular space to the intracellular space. Once it's activated by a growth factor, these two parts kiss and they start phosphorylating these intracellular molecules. Phosphorylation provides ATP, doesn't it? Which is energy. So it's giving energy to active reactions within the cells. There's two main pathways that will be activated by activation of a tyrosine kinase. Both of them impact growth in different ways and are responsible for upregulating VEGF and epidermal growth factors. So increasing angiogenesis and stromal cell growth. So if we've got, this is scary. Does everybody look at this and just go, oh, no, I'm out? Me too. Still, I reckon I knew what all of these were when I was doing my fellowship, and I've now I recognize one word in here. It's disappointing. I don't want you to worry about any of these little acronyms. The ones that are starred in this diagram are potential targets for inhibition. So when we say small molecule inhibitor, it's not necessarily inhibiting this part, the receptor. It's just blocking off the signaling pathway. And all you really need to know is that any point along here, if you inhibit it, the outcome is going to be you're going to get a reduction in growth factors being produced. Does that make sense? Okay.
And is it better to target small molecules on both sides of that flow chart to cover more bases?
Not necessarily. And what we're learning is that where we thought we were just inhibiting that one, the off-target effect was that we actually also got all of these things. So we weren't targeting anti-angiogenesis, but we actually got anti-angiogenesis and things. So we know that there's pieces of the puzzle that we don't really know about or understand yet, particularly in dogs, because we're quite often extrapolating from human intracellular signaling knowledge. So it's not as clear cut as that, I don't think. I'm going to work out how to stop sharing my screen now. There we go. Okay. So that's the main really confusing background of tyrosine kinase inhibitors. What do we use them for?
Mastocytosis.
Pretty much. That's what it's licensed for.
Hemangiosarcoma is what I see them using it more now, the oncologists.
Yeah. There's actually so many indications that there's demonstrated benefit. So where we thought we were doing KIT inhibition specifically, we've found that even in patients that don't have a KIT mutation or in patients with tumours that we don't really know what the KIT profile is, we're seeing effects that we didn't really understand, and that's probably the effect on T regulatory cells, the anti-angiogenic effects and the anti-stromal cell effects that we're getting kind of outside of the pathways we understand. So there's a lot more trial and error going on with these medications outside of mast cell tumours. Has anybody used them for anything other than mast cell tumours?
I think I have a lymphoma patient that the oncologists are thinking about using it on soon.
Yeah.
Sorry.
That's all right. I'm not sure about the effects with lymphoma, but why not? Really?
It's post, like this is its first rescue, and just looking at all options. So it's on the kind of list for future. Yeah.
There's been studies showing improved outcomes in patients with head and neck carcinomas, so including thyroid carcinoma, nasal carcinomas. There's GISTs, gastrointestinal stromal cell tumours, have been quite effective. I think Josh and I managed a cat on Palladia for about 2 years with a huge gastrointestinal stromal cell tumour, and it did really well. We did, didn't we? We did that. Yeah. Melanoma, acute myelogenous leukemia, epitheliotropic lymphoma, anal sac adenocarcinoma, feline injection site sarcomas, and osteosarcoma. So potentially lots of different effects, but as we talked about with the other like sort of targeted immunotherapy, we're not very good at predicting which patients are going to respond or not, and often it's too late when you realise they weren't a responder. So that's kind of the only downside, but it is a nice option, being administered at home and things. What are the risks of these medications?
Could die.
Did you say they could die?
I said GI.
Gee.
They could die.
They could die. It's very dramatic, man.
Well, yeah, I mean, it's probably going to happen, unfortunately, but I said GI.
Yeah, good.
I see a lot of GI complications from Tocranib.
Yeah. Proteinuria, hypertension, coat change, baldness. A lot of the side effects are similar to the chemo side effects, as far as sort of GI and neutropenia and things like that.
It's like hypertension as well, and like protein losing nephropathies, I think.
Yeah, which I don't think we really understand very well. It's a bit scary, but it's fairly infrequent, fortunately. Now I don't have academic access anymore, but I would recommend a paper by an oncologist called Cheryl London that was in the Veterinary Journal for Josh in particular. It's a review on tyrosine kinase inhibitors, and it just explains it really well and really clearly. And the other one, sort of follow-up reading from this section, is just building suspense. A Vet Clinics in North America paper, but it is from 2014. So I'm sure there's better. If someone can do a bit of a literature search for us, for tumor immunology update, a review, I think that would be, I would wish that I'd found it before this session, because 2014 feels way too old.
Anna, do you know if Gleevec has any different off-target effects as a TK inhibitor?
What's Gleevec again?
Imatinib.
Imatinib. No, I don't know. Oh, off-target.
Like with the small molecule inhibition.
No, I don't have.
Or if anyone knows anyone using Gleevec in Australia for lymphoma.
I don't know. Yeah, I don't know. Sorry, I've got notes on masitinib, but not imatinib. I'm actually going to wrap up, if that's all right with everybody. I've got at 9 o'clock that I'm going to run into. Thanks everyone for coming, and sorry for the rabbit warrenness. I can't remember what the next fortnight is, but I'm sure you'll find out in an email before we get to it. Thanks everybody for participating.
Thanks, Anna.
Thanks, Anna. See everyone.
Bye.
Bye.